At the outset, thank you, KMA, for giving us an opportunity here to be in front of you and discuss a complex topic like obesity. Thank you, ma'am, for your elaborate lecture. And because diet is a very core part in the management of obesity, and she has given an excellent introduction to this session. So, my topic is about obesity and management. Basically, how the drugs play a role, as well as what are the newer advances or what is the endoscopic role nowadays in management of obesity. So, as we all know, overweight and obesity are defined as abnormal or excessive fat accumulation that presents with health risks. So, the BMI is a standard measure on which we classify different types of obesity. So, if a BMI is of about 25 to 30, we categorize these patients into overweight category. And if the BMI is more than 30, these patients are obese. They are further classified as type 1, type 2 and type 3 depending upon the BMI furthermore. So, if we consider the epidemiology worldwide, the obesity has tripled since about 1975. In 2016, more than around 1.9 billion adults 18 years and older were overweight, and over these 650 million were obese. Why I am stressing this point is 1.9 billion adults who are overweight, not obese. Only 650 million people are obese. But many of these patients who present to us so commonly in our OPDs, when we see these patients have got early diabetes, these patients have got early hypertension, there is PCOD, there is infertility. These are more commoner patients what we see in our day-to-day life and day-to-day OPD, and they have non-alcoholic fatty liver diseases, mild early cirrhosis. All these problems are seen in these patients. So that is why what are the treatment options for such patients? In India, if you see, more than 135 million individuals are affected by obesity. These are the prevalences or comorbidities that are associated with obesity: hyperglycemia, dyslipidemia, cardiovascular diseases, hypertension, fatty liver, pulmonary diseases, PCOD, infertility, psychiatric disorders, osteoarthritis, and few cancers. So, obesity arises as the result of an energy imbalance between the calorie consumed and the calories expended, creating an energy surplus and a state of positive energy balance, which results in excessive body weight gain. So, for this there are many causes or many factors, which are: one are environmental, as madam had elaborated in the previous talk, socio-economic, some genetic factors, and some personal behaviors. Apart from, if you see all these four causes, apart from the genetic factor, all of these are reversible. So it is important to address these other three parameters. How do you address this? You can address this by the present options for such patients are: one are lifestyle changes. The total body weight loss with this kind of intervention is around 5 to 10%. Relapse and regains are common. Obesity pharmacotherapy. So the total weight loss was about 4.5 to 11%. They have side effects and intolerance. And then there was bariatric surgery, where there was excellent weight loss with 24 to 28%. The complication rate for some reason were high. There were weight regains. It was expensive. And the social acceptance was not there to some extent. So the problem here is that we have two extremes in the management of obesity. One is there is lifestyle change, there is pharmacological treatment, which is growing now, but they have side effects, and the other end is bariatric surgery. As I stressed in my previous slides, that most of these patients who present to us in OPD are overweight patients. They might have failed. The first thing what we do in management of obesity is lifestyle change. Initially, you do it personally, then you seek an expert opinion, and then try to change your lifestyle. But there are failure chances. obesity drug or pharmacotherapy, they can be intolerant. So in these patients, is the only option for these patients is surgery? I don't think so. There are many other parameter or new advances which have happened in management of obesity now, which I will elaborate. So these are the drugs. As you know that obesity is multifactorial. It depends upon the gut brain axis, and there are many drugs which addresses this particular problem. So initially we have tendency to eat more, so to reduce that we have centrally acting drugs. Then the motility of the intestine can be easily altered because of gut acting drugs, and secondly nowadays GLP-1 receptor agonists, which are centrally acting as well as gut acting, which increases the satiety, reduces the motility of the gut, as well as reduces the enzymes which are secreted by the pancreas, helping in better glucose control, better weight loss, and these are in research now. So the ideal requirement now was an effective and a durable, less invasive, easily performed, less complications, less expensive, and achieve desirable results. So that is where endoscopic interventions came into existence for management of bariatric surgeries. So these endoscopic bariatric therapies are divided into two, same as surgical, restrictive and malabsorptive. Restrictive, the most common is intragastric balloons, and malabsorptive, the common example is duodenojejunal bypass sleeve. There are many other examples I will come ahead with. So the endoscopic bariatric therapies, the most commonly now used are endoscopic space occupying devices, that is intragastric balloons, and gastric remodeling procedure like endoscopic sleeve gastroplasty. This is a counterpart to laparoscopic sleeve gastroplasty. So these are the malabsorptive procedures, that duodenojejunal diversion, gastroduodenojejunal bypass, jejunoileal diversion, and duodenal mucosal resurfacing. So what are the indications in endoscopic bariatric therapy? Are failed weight loss or weight maintenance with lifestyle interventions alone or with medicines, BMI of 25 to 35 with comorbidities, BMI of 35 or 40 not willing for surgery, or as a breach to the definitive surgical procedure. Intragastric balloons, they are mostly silicone based, they are endoscopically placed, they are partially filled with fluid or water, few are adjustable, they have better tolerability, they are short term placement, only about 6 months, easily removed, weight loss achieved by around 12 to 14%, and advantage is that it does not alter any anatomy and it is reversible. Ideal for BMI less than 40 or less than 30 with comorbidities. The mechanism is that it stimulates the stretch receptors in the stomach fundus and delays the gastric emptying, inducing early satiety. The side effects are crampy abdominal pain, nausea, vomiting, bleeding, ulcers, and other things which are very rare. These are the balloons which are available in the market now. The Obera is the most common. Apart from that, there is parts and other things. This is the new balloon which is available in market. This is called as an aileron balloon. This does not require an endoscopy, does not require an anesthesia or anything. Here, there is a capsule which is attached to a catheter, and as you swallow a normal capsule, you have to swallow it with a few sips of water, and with the catheter attached to it, you keep on pushing it till the mark is reached. Once it is reached, you can check the position of that particular balloon on fluoroscopy or in X-ray, that it is in the fundus or no. You can see that this is the catheter which I am holding, and it has a capsule at the end. And this patient, I have kept the balloon in the mouth, and as he is swallowing, I am pushing it down, and then we confirm that particular position on fluoroscopy, and then fill the other end of that particular catheter to a saline bottle about 500 ml, which is injected, and once the balloon is inflated, we just pull out the catheter. You did not remove it with endoscope or anything. And the best thing about this thing is that it stays for 4 to 6 months, and you don't have to remove it also. It ruptures on its own after about 4 to 6 months, and it passes out through stools. So this does not require anesthesia, this does not require endoscopy also, and it's a 15 minutes daycare procedure. Patient can be sent home within another 15-20 minutes after the procedure. So what are the results? We are talking about insertion. You can see in liver diseases, the steatosis reduces significantly, the ballooning on histopathology reduces significantly, even the NASH score, the inflammation, and also to some extent fibrosis. The common side effects are minimal: pain, nausea, vomiting, GRD, which can be controlled. Very less frequently, there is some migration or ulcer or perforation. Next, coming to endoscopic sleeve gastroplasty. This is a counterpart to surgical laparoscopic sleeve gastroplasty. What we do is, we have an endoscopic suturing device which we insert into the stomach, and we take random sutures around the greater curvature of the stomach, reducing the size of the stomach and making it like a tube. So the advantages is that the ESG is reversible, it is endoluminal procedure, it is an organ sparing bariatric procedure, done with commercially available full thickness endoscopic suture device, and we take interrupted suture, as I told you earlier, and large meta-analysis have shown that around 18 to 24% of total body weight loss can be achieved by ESG alone. The concept is that you create a sleeve or a tube which connects the LES to the lower esophageal sphincter to the antrum. Fundus is spared, as the fundus has mechanoreceptors and it delays the gastric emptying, and plus it converts a very low pressure high compliance system into a high pressure low compliance system, so that the intake of food is reduced. So these are the two comparisons. This is the laparoscopic sleeve and this is the endoscopic sleeve. You can see the suture line in the first thing. We can see here the sutures we have taken into the greater curvature of the stomach, making it similar to the tube as a laparoscopic surgery. So the results, you can see there is significant drop in the size of the stomach, there is good weight loss, the gastric emptying is delayed, we can see that the HOMA IR is reduced. You can see patients with F0 to F2 fibrosis, there is reversal. Indeterminate patients also there is reversal. Of course, F3 to F4 fibrosis are irreversible processes, so you don't see significant changes. But if you see 2 years randomized trial, there is reduction in ALT, AST, NAFLD score, HbA1c, and all those parameters which are metabolically important. The side effects, as I had elaborated earlier, same like moderate pain, nausea, nothing which cannot be tackled with medicines. Comparison with laparoscopic sleeve, around 18.5% to 20%, and around laparoscopic sleeve around 28% of weight loss. And if you see the complications with ESG, it is just 0.5 for 2-year follow-up, and it is about 4.5 in about laparoscopic sleeve. Compared to the other options or endobariatric also, you can see that ESG has comparable results with laparoscopic sleeve gastroplasties and even with balloon interventions. Now, as we know that about 18 to 24% of weight loss is achieved by ESG alone, now there is a study that when you combine ESG with GLP-1 agonist, something like a semaglutide, you can achieve total weight loss of about 34%, which is equivalent to a surgical malabsorptive bariatric procedure. So that can be done only with balloon and semaglutide, or with endoscopic sleeve gastroplasty and semaglutide when compared with each other. Other malabsorptive procedures which are now available are, one is, as I earlier told, that duodenojejunal bypass, where there is a ring which attaches to the duodenal bulb, and there is a Teflon coated coated mesh about 65 centimeters which covers the duodenum and the jejunum, so that the first and third part of the jejunum and the proximal jejunum are covered. So there is a malabsorptive effect for that. Other is duodenal mucosal resurfacing, where we can ablate the third part of the duodenal mucosa, where the sensations or where the enzymes for the pancreas, stimulation for the pancreas is there. So that can be reduced by resurfacing the mucosa. And third is self-assembly of the magnet. This is an answer to a surgical duodenal switch, where you can use an hexagonal magnet, place it in the first part of the duodenum, and then endoscopically put the second magnet in the terminal ileum and connect both the two, so there forms an anastomosis. So whatever the patient eats, that passes through that particular anastomosis directly into the ileum and to the colon, and through the normal route the biliaropancreatic secretions will reach that particular bolus, where the digestion happens in the terminal ileum or into the colon. So to the lack of time, I will just skip with this slides. The common side effects, as I told you, nausea, vomiting, pain, some early removal, and some liver abscesses and cholangitis very rarely. The last point I want to stress is that obesity is a cycle. Initially, there is an assessment of obesity, then you do an intervention where there is a significant weight loss. Then there is a phase where behavioral changes and other things takes place, and when there is a weight maintenance, and over 2 or 3 years of time, then what happens is the patient goes into a phase where there is a weight regain. So what do you do when there is a weight regain? So as in these patients, when there is a gastric bypass or you place a gastric pouch, the tendency of the stomach is to distend. So over a period of time, the stomach starts distending and the patient starts having normal diet. So you can do endoscopic revisions for these patients, where you can just take sutures around that particular pouch and make the pouch smaller in size, so that patient again has reduced or early satiety and reduced appetite. So this can be done. Revisions are also possible endoscopically these days in patients with weight regain. So to summarize, obesity is a pandemic. Most of the risk factors except genetic are reversible. Intervention is required when lifestyle modifications fail to prevent health issues. Endoscopic bariatric therapies are novel modalities. Daycare and effective procedures for weight loss. EBT combined with agonists can lead to weight loss comparable to the bariatric surgery. Right for overweight patients with comorbidities or BMI of 30 to 40. Restrictive endoscopic procedures are studied widely and would be a game changer in the management of obesity. Thank you so much for your patient listening.
Thank you, sir, for enlightening us with your knowledge.